The pancreas is a pear-shaped glandular organ. It is located in the center of the abdomen, between the stomach and the spine. It is made up of two major components, exocrine and endocrine. The exocrine component is made up of ducts and small sacs called acini. This part of the pancreas makes specialized proteins called enzymes. These are released in the small intestine to help body digest and break down food particles, particularly fats. The endocrine component is made up of cells lumped together in different locations within the part of the pancreas, which is called islets of Langerhans. These cells make specific hormones, the most important of which is insulin. Insulin is the substance that helps control the amount of sugar in the blood. This portion of the pancreas also makes other hormones such as glucagon, somatostatin, pancreatic polypeptide, and vasoactive intestinal polypeptide. Each of these hormones play an important role in regulating body's metabolism. There are several types of pancreatic cancer, mainly depending on whether the cancer began in the exocrine or endocrine component. Exocrine tumors are the most common types of pancreatic cancer. The most common type of exocrine tumor is called adenocarcinoma. Adenocarcinoma is not unique to the pancreas as it develops in the glandular tissue that lines most of the internal organs. When these tumors occur in pancreas, they usually start in the ducts of the pancreas called ductal adenocarcinoma. Much less commonly, if the tumor begins in the acini, it is called acinar cell carcinoma. An increasingly common diagnosis is called intraductal papillary mucinous neoplasm, which is also called IPMN. An IPMN is a tumor that grows within the ducts of the pancreas and makes a thick fluid called mucin. IPMN is not cancerous when it begins, but it could become cancerous over the time if not treated. Much rarer types of exocrine pancreatic tumors include acinar cell carcinoma, adenosquamous carcinoma, mucinous cystic neoplasms, pancreatoblastoma, solid pseudopapillary neoplasm, and there are a few others. Endocrine tumors are also called pancreatic neuroendocrine tumors or islet cell tumors. They are much less common than exocrine tumors, making up about 7% of all pancreatic cancers. This type of tumor is very different than what most people refer to as pancreatic cancer. A pancreatic neuroendocrine tumor can be functioning or non-functioning. A functioning tumor makes hormones. A non-functioning tumor does not make hormones. A functioning neuroendocrine tumor is named based on the hormone the cells normally make. These include insulinoma, glucagonoma, gastrinoma, somatostatinoma, VIPomas, and like others. There are minor variations in treatment of various neuroendocrine tumors as compared to pancreatic adenocarcinomas. In 2020, nearly 5 lakh people were diagnosed with this cancer. Pancreatic cancer is the 4th leading cause of cancer-related deaths in the world. In general, the following factors may raise a person's risk of developing pancreatic cancer. The risk of developing pancreatic cancer increases with age. Most people who develop pancreatic cancer are older than 45 years. More men are diagnosed with this cancer than women. People who smoke tobacco are 2 to 3 times more likely to develop pancreatic cancer than those who do not. Regular eating foods that are high in fat is a risk factor for pancreatic cancer. Research has shown that obese and even overweight people have a higher risk of being diagnosed with and dying from pancreatic cancer. Chronic heavy alcohol use can also increase the risk of this cancer, most likely by causing recurrent pancreatitis, which is a repeated inflammation of the pancreas. Pancreatic cancer may run in the family. An individual is at high risk if 2 or more first-degree relatives or at least 3 members of the family have been diagnosed with this cancer. First-degree relatives include parents, children, and siblings. One should consult a genetic counselor to discuss the need for genetic testing. There are certain hereditary syndromes such as hereditary pancreatitis and Peutz-Jeghers syndromes, which run in families and increase a person's risk of pancreatic cancer. This can be very well detected by genetic testing, and screening methods can be implemented to detect the cancer at a very early stage. All patients with pancreatic cancer are advised to undergo genetic testing. Chronic pancreatitis is the inflammation of the pancreas. It is a painful pancreatic disease. Some research suggests that having chronic pancreatitis may increase the risk of developing pancreatic cancer. Apart from these risk factors, some studies have shown long-term diabetes to be a risk factor for pancreatic cancer. However, the exact cause and effect relationship is yet to be established. We see a lot of patients who are diagnosed to have diabetes and soon, in a month or so, they are detected to have pancreatic cancer. This is a kind of an inverse relationship as the tumor within pancreas affects insulin secretion. There are some associations found in medical literature for pancreatic cancer such as H. pylori bacterial infection, hepatitis B virus infection and cirrhosis. They may or may not turn out to be the risk factors in the future. Pancreatic cancer is often called a silent cancer as the signs and symptoms are not prominent in early stages of the disease. Some of the early symptoms can be reduced appetite, unexplained weight loss, and weakness. A recent onset diabetes can be a sign of a developing pancreatic cancer. The tumor may obstruct the pancreatic duct, which leads to reduction in digestive enzyme output from the pancreas. The result may be indigestion and passage of stools which are oily and sticky. When the tumor increases in size, it can occlude the bile duct, which produces jaundice, that is yellowishness of eyes and skin. If the tumor obstructs the duodenum, which is the initial part of the small intestine, the patient will experience nausea and vomiting. Bilirubin is a chemical that may reach high levels in people with pancreatic cancer due to blockage of the common bile duct by the tumor. There are many other non-cancerous causes of an elevated bilirubin level such as hepatitis and gallbladder stones. CA19-9 is a tumor marker. A tumor marker is a substance which is produced by the tumor that may be found at a higher level if the cancer is present. CA19-9 levels are often increased in people with pancreatic cancer, although some patients may have normal CA19-9 levels. CA19-9 levels often become higher if the cancer grows or spreads. So it should not be used as the only test to diagnose pancreatic cancer because high levels of the tumor marker can also be found in some non-cancerous conditions such as pancreatitis, cirrhosis of liver and non-cancerous blockage of the common bile duct. A special CT scan method which is called pancreatic protocol CT scan is used in this cancer. This method focuses on taking pictures of the pancreas at specific times after the intravenous injection of the contrast. This is done to find out exactly where the tumor is in relation to nearby organs and blood vessels. The results of this test can help decide if the tumor could be removed with surgery. An MRI may also be advised which can complement or replace the CT scan. A special type of MRI called ERCP is used for pancreatic cancer. PET scan, also called PET CT scan. This is a special test that identifies tumor spread to the lymph nodes as well as distant organs such as liver or lung. This test uses a radio tracer substance which is called FDG. Tumor lights up as it retains the radio tracer. PET CT scan is done selectively in pancreatic cancer patients. Endoscopic retrograde cholangiopancreatography, the short form is ERCP. It is an endoscopic procedure which is performed by a gastroenterologist, which is used to put a plastic or a metal stent in the biliary system to reduce the jaundice. Samples of the tissue can be taken during this procedure and it can sometimes help confirm the diagnosis of cancer. The patient is usually lightly sedated during this procedure. Endoscopic ultrasound uses a high frequency ultrasound probe which is pushed inside the stomach and around the pancreas to create high quality images of the pancreas. The procedure is performed by an expert gastroenterologist and patient is kept sedated during the procedure. A biopsy is a test by which a small sample of tissue is examined in the laboratory by a doctor called pathologist. It will confirm or refute the diagnosis of cancer. The sample of tissue is usually obtained by a test called endoscopic ultrasound, which we just discussed. All pancreatic cancer patients do not need to undergo biopsy prior to surgery. The biopsy is planned in patients in whom the diagnosis of cancer is doubtful or in whom the chemotherapy is planned as a treatment option. Knowing the stage of the disease helps the doctor to recommend the best kind of treatment and also can help predict a patient's prognosis, which is a chance of recovery. The more common way to classify pancreatic cancer is to classify the tumor into one of four categories based on whether it can be removed with a surgery and where it has spread. The first is resectable pancreatic cancer. This type of pancreatic cancer can be surgically removed. Surgery is often done right after the diagnosis. Sometimes additional treatment may be recommended before surgery. The tumor may be located only in the pancreas or extend beyond it, but it has not grown into the important arteries or veins in this area. There is no evidence that the tumor has spread to areas outside of the pancreas. Approximately 10 to 15% of the patients are diagnosed with this stage. Second is borderline resectable pancreatic cancer. This category describes a tumor that may be difficult or not possible to remove surgically when it is first diagnosed. But if chemotherapy and or radiation therapy is able to shrink the tumor first, surgery may be possible to remove the tumor later with a negative margins. A negative margin means that no visible cancers are left behind in the body. Third type is locally advanced cancer. This type of pancreatic cancer is still located only in the area around the pancreas, but it cannot be removed surgically because it has grown into or close to nearby arteries, veins or organs. This means that it cannot be removed with surgery because the risk of damaging these nearby structures is too high. There are no signs that it has spread to any distant part of the body. Approximately 35 to 40% of the patients are diagnosed with this stage. The fourth type is metastatic pancreatic cancer. Here the tumor has spread beyond the area of pancreas and to other organs such as liver, lungs or distant parts of the abdomen. Approximately 40 to 45% of the patients are usually diagnosed with this stage. In cancer care, different types of doctors and other healthcare professionals often work together to create a patient's overall care and treatment plan that combines different types of treatment and supportive care. This is called a multidisciplinary team. Treatment options and recommendations depend on several factors, including the type and the stage of the cancer, possible side effects, and patient's preference as well as overall health of the patient. Surgery for pancreatic cancer includes removing the part of the pancreas depending on the location and the size of the tumor in the pancreas. An area of healthy tissue around the tumor is also often removed. This is called a margin. A goal of surgery is to have a clear margins or a negative margin, which means that there are no cancer cells at the edges of the healthy tissue removed. Surgery for pancreatic cancer may be combined with chemotherapy and or radiation therapy. Typically, these additional treatments are given after surgery, which is called adjuvant therapy. However, systemic therapy and or radiation therapy may sometimes be used before surgery to shrink the tumor. This is called neoadjuvant therapy or preoperative therapy. After neoadjuvant therapy, the tumor is restaged before planning the surgery. Restaging is usually done with another computer tomography, which is a CT scan, to look at the change in the tumor size and what nearby structures and blood vessels it is affecting. Different types of surgery are performed depending on the purpose of the surgery. Sometimes the surgeon may choose to start with a laparoscopy. During a laparoscopy, several small holes are made in the abdomen and a tiny camera is passed into the body while the patient receives anesthesia. During this surgery, the surgeon can find out if the cancer has spread to other parts of the abdomen. If it has, then surgery to remove the primary tumor of the pancreas is generally not recommended. In all the surgeries, nearby lymph nodes are removed as a part of the operation. Whipple's procedure is also referred to as pancreaticoduodenectomy. A Whipple procedure is done if the cancer is located only in the head of the pancreas. This is an extensive surgery in which the surgeon removes the head of the pancreas and the part of the small intestine, also called duodenum, as well as the bile duct and the stomach. Then the surgeon reconnects the digestive tract and biliary system. Distal pancreatectomy is another surgery which is commonly done if the cancer is located in the body or tail of the pancreas. In this surgery, the surgeon removes the tail and the body part, which is the left side of the pancreas, along with the spleen. Total pancreatectomy. It is done if the cancer has spread throughout the pancreas or it is located at many areas in the pancreas. So the word total pancreatectomy means removal of the entire pancreas. Supportive surgery and palliative procedures are often recommended to help the patient with the symptoms which are affecting the quality of life. Examples of palliative procedures and surgery includes a bypass surgery, a stent placement, and nerve blockage to alleviate jaundice, nausea and vomiting, and tumor-associated pain respectively. Locally advanced pancreatic cancer is usually treated by combination of chemotherapy and radiotherapy. Metastatic pancreatic cancer will be managed by various combinations of chemotherapy, targeted therapy, and immunotherapy.